All right. So let's push through senses and then we will be done. So sensory receptor cells are going to be classified functionally by the types of stimuli that activate them. So our chemoreceptors are going to react to chemicals, including odors, tastes, and the concentration of such chemicals, such as glucose or carbon dioxide. Mechanicoreceptors, those will respond to factors such as pressure, stretch, and vibration. Thermoreceptors are going to be activated by a change in temperature. Nociceptors, those are going to be pain receptors that respond to tissue damage from trauma, as well as from your heat, chemicals, pressure, or a lack of oxygen. Your photoreceptors are going to respond to light found only in the eyes. Proprioceptors are going to be found in skeletal muscles, joints, and tendons. And then they'll provide information about body movement, muscle strength, and the general orientation of the body. Microscopic general sense organ receptors are going to be found in almost every part of the body, but they are most concentrated in the skin. However, these receptors are not evenly distributed over the body surface or in the internal organs. Also, they are not going to respond to the same type of stimulus. So, stimulation of general sensory receptors can lead to a variety of sensations. The difference in which the kind of stimuli is detected is called the mode of sensation. So different general sensory receptors can detect vibration, deep pressure, light pressure, pain, stretch, or temperature. Vision will detect the color and intensity of light in our external environment, but when it's focused by the eyes and processed by the brain, it can do much more. We can recognize the outlines and the depth of objects, analyze movements, and determine distances. When you look at a person's eye, you will see only a small part of the whole eye. So the eyeball is going to be a fluid filled sphere having a wall of three different layers. The fibrous layer is going to be composed of the sclera, and then the white part of the eye, which is made up of dense bundles of collagen fibers, and then the cornea, which is the transparent circle on the anterior fibrous layer and sometimes called the window of the eye. A mucous membrane known as the conjunctiva will line the eyelids and cover the fibrous layer in the front. The blood vessels that you see on the surface of the sclera actually belong to the conjunctiva. So when the conjunctiva is inflamed, it's known as conjunctivitis, and it's typically caused by a bacterial or viral infection, allergy, or environmental factor. The vascular layer, or the middle of the eye, which is made up of a dense network of blood vessels. Most of the vascular layer is made up of the choroid, which contains a large amount of dark pigment melanin. This almost black layer will help prevent the scattering of incoming light rays, which could make it hard for the eye to focus on an image. Several involuntary muscles make up the anterior part of the choroid, and some of the iris, or that colored structure that's seen through the cornea, the black center of the pupil. I'm sorry, the black center of the iris is really a hole in the donut shaped muscle known as the pupil. Most of the fibers of the iris are going to be arranged like spokes within a wheel. When they contract, the pupils dilate, letting more light rays in. And then the lens of the eye is directly behind the pupil, and it's going to be held in place by a ligament that's attached to an involuntary muscle called the ciliary muscle. When we look at distant objects, that ciliary muscle is going to be relaxed, and then the lens has only a slight curved shape. To focus on your object, the ciliary muscle must contract, and as it contracts, it pulls the choroid forward towards the lens. Therefore, it's going to cause the lens to bulge and then curve even more. The retina makes up most of the inner layer of the eyeball. It contains the microscopic photoreceptor cells to direct light called rods and cones, and they're named this because of their shape. Dim light is various wavelength or colors can be stimulate the rods, giving us the monochrome vision um, when our lighting is low. However, fairly bright light is necessary to stimulate those cones. So simply put, our rods are going to be the receptors for night vision, and then the cones are going to be the receptors for our daytime vision. Fluid will fill the hollow spaces within the eyeball. They maintain the normal shape of the eyeball and then help refract light rays. Aqueous humor is the name of the liquid in front of the lens, so in the anterior chamber of the eye. And then the vitreous humor is the name of the jelly-like fluid behind the lens, or the posterior chamber of the eye. So light will enter through the pupil and it's going to be refracted so that it's focused on the retina. The innermost layer of the retina will contain the cones and rods in which to respond to a light stimulus by producing a nerve impulse. The rod and cone photoreceptors will synapse with neurons in the bipolar and ganglionic layers of the retina. After leaving the eye, the optic nerve enters the brain and travels to the visual cortex of the occipital lobe of the cerebrum, and eventually visual interpretation of the nervous impulses generated by light striking the retina that will result in vision. So some of our pathology of the eyes, your ptosis is just the drooping of that upper eyelid. So it's not even really the lid itself. It is kind of that fatty portion that's right underneath the eye. Your blepharitis is going to be just a swelling of the eyelid. Your ectropion is going to be an E version of the edge of an eyelid. And then your entropion is going to be where it goes inwards. The additional adnexa pathology. So your conjunctivitis itself is going to be what's known as pink eye. Dacryoadenitis is going to be an inflammation of the lacrimal gland. Uveitis is going to be an inflammation of the uvea. Corneal ulcer is just going to be an open sore on the cornea. And then your scleritis is going to be an inflammation of that sclera. Some of the eye itself, some of the most common ones you'll see are the retinal detachment. So there's actually a separation of some or all of that light sensitive retina that has become detached. Your diabetic retinopathy, that's going to be pretty common, especially in patients that have diabetic or that have diabetes that are diabetic. So there's just going to be damage to that retina itself. Our glaucoma, again, it's going to be very common in patients that are diabetic. So there's just that intraocular pressure that is elevated, and it's going to cause damage to those fibers in the optic nerve. So if it is open angle, it's going to be a chronic glaucoma. If it is closed angle, it'll be acute. Macular degeneration. It's going to be that the macula at the center of the retina is damaged. So it can either be age-related or non-age related. And then down here for the functional defects, you see diplopia, where you just double vision, color blindness, photophobia, which is excessive sensitivity to light. That'll happen a lot whenever you see someone with migraines. So just kind of keep that in mind if it is documented as photophobia. Strabismus, that is just going to be a deviation of the eye. So it's either going to go inwards or outwards. Your astigmatism, so your eyes just aren't able to focus properly. I have astigmatism. Sometimes it doesn't bother me during the day. But if I'm driving at night, then that is when it tends to bother me more than not. And then some diagnostic procedures. You've got a refraction test that just kind of determines the eye's refractive error, so how well it can focus. Your visual field testing, which is just going to help you determine any losses in your peripheral. So when you go to the doctor and they like pull their finger and they go all the way back by your ear, they're just waiting to see when you can actually see it moving forward. my goodness, I can't say it. Optimal. I can't do it tonight. I don't know. This one is always a struggle for me. If I start this, if I start a day with I can say it. But basically, it just looks at one of the eyes. So if you have one of those corneal abrasions or corneal ulcer, then they can drop fluorescent drops into your eye and take that slit lamp, and it will help illuminate any like abrasions or ulcers or anything like that on your eyes. If you see PERRLA, that is for pupils are equal, round, reactive to light, and accommodation. So essentially, it means that your eyes are functioning the way that they should. They're responding the same way, all of those things. Your tarsa wrapping, that's going to be a complete suturing of upper and lower eyelids. So when your eyes are unable to close normally, they will actually suture them closed to help them heal appropriately. When you talk about corneal transplants, that's also known as a keratoplasty. Enucleation is just the entire removal of the eyeball, but it does leave those eye muscles intact. And then you can have an eye prosthesis or an artificial eye that's placed in. Scleral buckle is going to be a silicone band or a sponge that's used to help attach or repair a detached retina that does happen over time. And then your intraocular lens. So basically, it's a replacement for that natural lens. It can be monofocal or multifocal if it needs to be. And then our corrective lenses, they don't have to be implants, but they are more than likely just going to be like your eyeglasses that you see. So they can be used for nearsightedness, farsightedness, bifocals, trifocals, and then you have contact lens that go directly on the eyeball. And then your laser treatments, so like your LASIK, photocoagulation, things along those lines. And then for the ears, so the ear is going to be more than just an appendage that's on the side of the head. You do have a large part of the ear, and it's the most important functional part that is hidden from deep view, that's found deep inside the temporal bone. So the ear is going to be divided into 3 anatomic areas. The external ear has 2 parts. You have the auricle, which is the appendage on the side of the head that surrounds the opening of the exterior acoustic canal. And then the external auditory canal itself is that tube that curves. It's about 1 inch in length, and it extends into the temporal bone and ends at the tympanic membrane or in the eardrum. And then that eardrum is going to be a partition between the external ear and the middle ear. The skin of the acoustic canal, especially in its outer 1/3, will contain many short hairs and ceruminous glands that produce a waxy substance called cerumen. While it helps the canal from that skin from drying, any excess cerumen within the canal can impair your hearing by absorbing or blocking the passage of those sound waves. The middle ear is going to be tiny and very thin epithelium-lined cavity that's hollowed out of the temporal bone. It's going to be an air-filled space housing 3 very small bones known as the ossicles, and they're named the malleus, the incus, and the stapes. The handle of the malleus is going to attach to the inside of the tympanic membrane, and then it's going to attach to the head of it is going to attach to the incus. The incus attaches to the stapes, and the stapes presses against a membrane that covers a small opening, which is known as the oval window. The oval window will then separate the middle ear from the inner ear, and when sound waves cause the eardrum to vibrate, that movement is transmitted to amplify the ear ossicles as it passes through the middle ear. The auditory canal or the eustachian tube will connect the throat with the middle ear. And then the epithelial lining of the middle ears, the auditory tubes, and throat are going to be extensions of one continuous membrane. A sore throat may spread to produce a middle ear infection, and that's also known as otitis media. The inner ear, that's going to consist of 3 spaces in the temporal bone assembled in a complex maze called a bony labyrinth. This odd-shaped bony space is going to be filled with watery fluid called perilymph, and it's divided into the vestibule, the semicircular canals, and the cochlea. The membranous labyrinth is going to be a balloon-like membranous sac that is suspended in perilymph and then follows the shape of the bony labyrinth, much like a tube within a tube. Sound waves are simply pressure waves within the ear. Such waves can be funneled by the auricle into the external acoustic canal and strike the tympanic membrane. Sound waves will cause the eardrum to vibrate, and then that movement is then transmitted and amplified by the ear ossicles as it passes through the middle ear. The movement of the stapes against the oval window will then cause movement of the perilymph fluid in the inner ear, which will then in turn trigger vibrations of the window. The vibration waves will now travel through the fluid of the inner ear to the organ of Corti, and then it lies within the curling snail-shaped membranous tube within the bony cochlea and is surrounded by ciliated hair cells on the spiral organ will generate nerve impulses when they are bent by the movement of endolymph and then set in motion by waves. This activation of mechanoreceptors in the spiral organ inside the cochlea of the inner ear will generate nervous impulses that travel through the cochlear nerve to the brain and results in hearing. So the mechanoreceptors for our sense of balance are going to be located in the sac-like vestibule and the 3 semicircular canals of the inner ear. Within the vestibule are going to be 2 structures, each made up of a patch of sensory hairs that are coated with a thick glob of heavy gel. Each of these structures is called a macula. When you bend your head, gravity acts on the heavy gel to pull it one way or another. This in turn bends the cilia of the hair cells and then produces a nerve signal. This signal is then interpreted by the brain as our sense of gravity or static equilibrium. The 3 semicircular canals are half circles oriented at the right angles to one another. Within each canal is a dilated area called the ampulla that contains a sensory structure called crista ampullaris, which will then generate a nerve impulse when the speed or direction of movement in your head changes. This sense of motion is called your dynamic equilibrium. Nerves from mechanoreceptors in the vestibule join those from the semicircular canals to form the vestibular nerve. The vestibular nerve will then join with the cochlear nerve to form the vestibulocochlear nerve. Eventually, the nerve impulses passing through this nerve will reach the cerebellum and the medulla, and then ultimately they will reach the cerebral cortex. So we've got some pathology of the ears and the hearing. So within the outer ear, so essentially from your eardrum out, you can have your impacted cerumen, which is just excess earwax. Otitis is going to be any type of inflammation of the ear. Otorrhea is going to be if there's any type of discharge from the ear. And then if you have otorrhea, that's going to be bleeding. So your middle ear, that's going to be from your eardrum up until that window. So then you're going to have like barotrauma. So that's going to be anything that's related to like pressure. Your infectious myringitis, that's just going to be some type of contagious inflammation of the ear. Otitis media, so you can have inflammation of the middle ear. So it can either be acute, which is typically associated with that upper respiratory infection, versus your serous otitis media, which is going to have some type of fluid buildup that causes that infection. And then some of your inner ear, you'll have your labyrinthitis, so inflammation of the labyrinth. Meniere's disease, it is relatively rare, but it does have it is where you have an amount of fluid in the inner ear that does tend to increase intermittently, which will throw off your equilibrium. And then if you ever experience that ringing or buzzing in one or both of your ears, that's known as tinnitus. When it comes to hearing loss, it can be complete or partial whenever it comes to deafness. So just depending on, the amount of, what you're unable to hear. And then if you have noise-induced hearing loss or NIHL, it can be permanent. But most of the time, if you walk away from that decibel, those high decibels, if you walk away from that, then you can resume hearing later after some time. Some of your diagnostic procedures. So if you have an otoscope, that really isn't a procedure, but it's a instrument that they use to examine, within that external ear. Tympanometry, that's just going to measure the pressure within the ear canal. If you ever have a doctor that has like that little that tuning fork, and they bang it and they say, "Can you hear this?" And then they do it in different. Some of them are louder, some of them are softer, some are higher, some are lower. And it's going to be the Weber and the outer ear. So some of our treatments, you can have an otoplasty. So it basically is just the surgical repair of, the outer portion or the pinna of the ear. Whenever middle ear wise treatment, you've got tubes. Um, they are used to be called tympanostomy tubes, but not, and everybody's going to remember that name, so they literally just now call them ear tubes. Myringotomy is if they have to do a small surgical incision to help relieve any of that increased pressure within the eardrum. And then a tympanoplasty, if you have a whole eardrum, whether it be from an ear infection, whether it be from trauma, whether it be because you shoved your Q-tip in too far, they can actually go and repair those. And then within your inner ear, a labyrinthectomy. So they may have to remove a portion or all of that labyrinth. And it can cause complete hearing loss within that affected ear. Treatments for your hearing loss. You have listening devices or hearing aids, cochlear implants, things along those lines. And then I lied. Don't be mad at me. We still have the taste, but this is only like 7 slides. I promise it's not that long. So the sense of taste or gustation that allows us to chemically analyze food before we bite or swallow it. The taste buds are going to be the sense organs of taste, and that they can contain both supporting cells and chemoreceptors called gustatory cells. So these cells will generate the nervous impulses ultimately interpreted by the brain as our taste. Although a few of our taste buds are located in the lining of the mouth and on the soft palate, most are going to be located on the sides of the much large and differing shaped bumps that are scattered across the tongue called the papillae. Each taste bud will open into a trench-like moat that surrounds the papilla, and it is filled with saliva. Chemicals dissolved in the salivas will stimulate the chemoreceptor gustatory hairs, and then nervous impulses that are generated by stimulation of taste buds travel primarily through 2 cranial nerves, which are 7 and 9, and those will end in the taste area of the cerebral cortex. Physiologists have originally counted 4 primary taste sensations: sweet, sour, bitter, and salty. Those will permit us to detect sugars, acids, alkaline, and sodium ions that are dissolved in our saliva. However, the primary taste sensations have expanded to include several others present within most individuals. So taste or metallic taste and umami, those have been added to the list of primary tastes, but they do tend to grow. So it wouldn't surprise me if, in a couple of years we have another one. Now, the sense of smell or olfaction that helps us, that helps detect certain chemicals in our environment. So the chemoreceptors responsible for olfaction are located in a small area of epithelial tissue within the upper part of the nasal canal. The location of the olfactory receptor is somewhat hidden, and we most often forcefully sniff the air to smell delicate odors. Each olfactory cell has a number of sensory cilia that detect different chemicals and cause the cell to respond by generating a nervous impulse. To be detected by the olfactory receptors, chemicals must be dissolved in the watery mucus that lines the nasal cavity. So the olfactory receptors are extremely sensitive and respond quickly to even very slight odors. However, after a short time, they then develop a kind of fatigue and lose their ability to respond. This decrease in receptor sensitivity is called adaptation, and that explains why odors that are very first noticeable are soon not sensed at all. After olfactory cells are going to be stimulated by our odor causing chemicals, the resulting nerve impulse will travel through the olfactory neurons and the olfactory bulb and cranial nerve 1, and then it enters the thalamic and olfactory sensors of the brain. And then we just have a couple of slides here of med terms, so suffixes for the senses. You've got aesthesia for sensation. So anesthesia is going to be that lack of sensation. Algesia is pain. Osmia, sense of smell, and guisia is sense of taste. And then here's some word roots for ear. Oh my God. Hearing and ear. I keep trying to say like totally wrong. I don't know what I'm trying to say. I'm not going to go over all of these because I'm sure everybody's kind of in information overload. I've kind of thrown a lot at you guys tonight. So I'm just going to kind of flip through these. Do any of these kind of stick out to you guys that you've seen before, or are most of them pretty fairly new to you?
I'm gonna say pretty new to me.
Yeah.
And because I
Medterm is,
work, and because I work with the coders, I've seen some of them.
yeah, you've seen some of them. And that's what's so hard about midterm is it's really hard. Like practicing it is where you guys are going to see it. So I can sit here and read off on all of these slides, like oxia means this and opia means this, and all of those things. But as you all get into like the exercises in the book and the blackboard and like all of things, that's what's really going to help you guys like reiterate them. I like to just kind of have them in here so that we can see them a little bit here and there. Don't really spend a whole lot on quote unquote the term portion of it. It's mostly the anatomy and that's where we talk. And then you guys will get your practice with your midterm within Blackboard. But obviously, if you have any questions